Welcome everyone for our last Controversies in Cardiology and the Simon Dack Lectureship and the Ananda Sharma Visiting Professorship. This year we had really a spectacular lineup of guest visiting professors, but most importantly, always very important to remember that what makes this successful is the hard work our fellows have put in. So I just wanted to acknowledge the fellows who made the program what I think is one of the top programs that we can have for our training program, as well as those people who see us live on the internet. In September, we had Mark Cohen and Dina Goldwater was the fellow who presented in that. Spencer King was in October, Ari Pollack. Andrew Marks in November. Sumit Shah did a great job. Dr. Stevenson in December. Sandeep Gangridi in January. Dr. DeMaria, Brandon Wiley did his program. Andrew Epstein in February. Ed Lynn prepared an excellent monograph. Dr. Lascalzo in March. Jonathan Feig presented and was a panelist. Dr. Ellenbogen in April, and Tiziana Scarabelli did an excellent job. We had Barry Kohler in May, and Ben Hirsch did his program, which was superb. And we're really privileged this month, as our last visiting professor for this academic year, to have Chris O'Connor, and Vicky Soto will be presenting. Just to remind people that this is seen on live, as well as our archive programs on the website www.heart-talks.org. All of these are archived. They're really excellent programs. This one particularly, we're privileged to have the three editors of JACC, the incoming editor, Dr. Fuster, who's in the audience, Dr. Narula from JACC Imaging, and Dr. O'Connor, JACC Heart Failure. That's quite a statement to have all three of them in one room in one conference. This is a particularly interesting conference, and I'm sure there's going to be a lot of controversy. Dr. O'Connor will be more formally introduced by Dr. Fuster in a few minutes. First, give your attention to Vicky Soto, one of our fellows, who's going to give a brief overview of the subject. Vicky.
Thank you, Dr. Goldman. Hello, everybody. Welcome to Controversies. I'm Vicky Soto. I'm one of the first-year fellows, and thank you for Dr. O'Connor coming, shedding light in one of the most controversial parts of the field, and our panelists as well. So heart failure, once thought a simple disease of deranged hemodynamics, is now known to be much more complex disorder involving multiple biological pathways. It is one of the most prevalent diseases, the leading cause for hospitalization in patients over the age of 65, and associated with great mortality worldwide, exceeding most cancers. As our elderly population continues to grow, so will heart failure. And so what are we to do? Currently, our assessment of a patient is based primarily on soft parameters, such as reported symptoms. It is therefore not surprising to hear that only 25 to 50% of patients are correctly diagnosed with heart failure in the outpatient setting. The difficulty in diagnosing this disorder emphasized the need for a more discrete parameter to be used, such as biomarkers. Biomarkers provide an objective finding that should be used in conjunction to standard care. By definition, it's a measurable biological parameter that serves as an indicator of a normal biologic process, pathogenic process, or pharmacologic process in response to a therapeutic intervention. In the field of heart failure, the most notorious biomarkers are the natriuretic peptides, the BNP and the anti-proBNP. And as you know, the prohormone BNP is produced in the heart in response to myocardial stretch, plays a crucial role in maintaining volume homeostasis, and this in turn is cleaved into BNP and proBNP. Anti-proBNP are measurable peptides. I'll begin with what we know now about the role of biomarkers in heart failure. Traditionally, they've been used as the gold standard in diagnosing heart failure in the acute setting, and current guidelines by all major cardiovascular societies recommend it for this use. As shown by the landmark study, the Breathing Not Properly trial, natriuretic peptides are the single best predictor of heart failure in patients presenting in the ED with shortness of breath, superior to symptom history, physical exam, and diagnostic tests. And just as notable, have great value in excluding heart failure as the diagnosis. But there's no controversy here. What about biomarkers for the use in the prognosis and management of heart failure? Patients discharged after hospitalization for an acute decompensated episode still have very poor prognosis, 1 in 4 being readmitted within 30 days of discharge. And biomarker levels have been shown to predict adverse outcomes in the short term. Now, none of that matters, though, if we don't use this information to change our therapy in order to improve outcomes. At this time, management is a one-size-fits-all method with the up-titration of medications to their clinical trial dosages. Biomarker-guided therapy is the tailoring of medications to a target biomarker level, and it is similar to the management of A1C and levels with patients with diabetes, and results show a trend towards improved outcomes. But it's still a Class 2B recommendation in the acute setting and 2A in the outpatient setting. Meta-analysis performed by our guest of honor, as well as others, have shown optimistic results, with the biomarker-guided therapy arm having an approximate 30% reduction in the risk of all-cause mortality. But before we get too ahead of ourselves, biomarkers have their limitations as well. Their levels are subject to various factors, including obesity, age, renal function, and so their interpretation is complex. As heart failure is a multifaceted disease involving multiple cascades, such as inflammation, ischemia, fibrosis, remodeling, novel biomarkers representative of these other pathways are being studied as well to help in the prognostication of heart failure. In conclusion, considering the prevalence of heart failure and the morbidity and mortality it carries, biomarkers as an objective tool for the use in the secondary prevention and maybe even the primary prevention of heart failure draws excitement. Up to this point, the disease complexity, variable study outcomes, and the limitations in biomarkers themselves have made the role in heart failure unclear, yet optimistic. Thank you.
Yeah, it's impressive what you did, Vicky, because you presented here an outline which is like a paper that just came out from the printing. Very well structured, and you have to be congratulated. Wonderful. Well, it's certainly, I'm very, very pleased to introduce a great friend and colleague, Dr. Chris O'Connor, and I'd like to say a few words about him. First of all, he graduated, he obtained the MD degree at the University of Maryland in Baltimore. And then very soon, actually, he spent 3 years at NIH, which is, to me, was probably the roots of why he's one of the most academically oriented cardiovascular specialists that I know today. He really is a doctor, he's a thinker, and he's a fantastic investigator, as I will show to you this in a couple of minutes. He did his internship after NIH, his internship at Duke, internship in medicine, chief medical resident, fellow in cardiology, and then he became associate in medicine. I guess he got into the staff at Duke, actually in 1989. Then he had obtained one title after the other, which is the way that we can present him today. He became chief of the Division of Clinical Pharmacology in 2001, and then eventually was chief of the Division of Cardiology and then director of the Duke Heart Center, and most recently, in addition, editor-in-chief of the Journal of the American College of Cardiology on the heart failure. It is interesting, among the titles, he was Associate Professor of Psychiatry and Behavioral Sciences, and maybe you will tell something about this later to better understand how did you get there. Did you have a crisis, maybe? Anyway, but very accomplished individual. Actually, he has written so much, over 500 papers. in all the topics related to cardiac failure. And I can divide this in three different groups. Actually, one is the so-called characterization and risk prognostication and phenotype, to see how this can be predicted. Then he moved into the surrogate endpoints in clinical heart failure and the biomarkers, which is the issue that you are going to address today. But he is like a pharmacologist. He has been really working in a number of novel pharmacological and non-pharmacological approaches to heart failure, which we had the great pleasure to listen to him today at noon. Now, it's quite impressive. He's one of the people that I know, maybe one of the 3 to 5 people that I know that got more grants at NIH than anybody else. And this is really fantastic. It's a constant over the years. And this is also goes along with the fact that he has been actually counted as, he has been either a principal investigator, co-investigator, or on the monitoring board of 60 different trials. I could go on and on about him and certainly talk about his awards and so forth, but he's a wonderful person to work with. I have been working with him over the last few months since he's the editor of one of the JACC journals. And certainly it's a pleasure to work with him. And again, I want to emphasize that at least the message that I want to get from him today is that he is not only a clinician, but he's a wonderful investigator, and he has proven this by competitive grants at the NIH level. So he's not somebody who you can say has not done the right job. Anyway, Chris, I want to give you this plaque to remember your visit today. And the plaque, as you know, relates to Simon Duck in one way as memorial lecturer, and to the father of Dr. Samin Sharma. And this is what you read here as the Mount Sinai is very grateful to you. Thank you very much for coming.
Thank you very much.
Okay, thank you. I'll give this to you. Okay, I'll give this to you. And you can sit actually in the middle. I feel like being on vacation. I feel so relaxed today because I have to do nothing. Just introduce a friend, which is easy to do. But now we are going to introduce a moderator, Dr. Michael Domansky. And then the people who are going to be in the panel, I will be sitting here enjoying. So Ajit is here. Dr. Penny is here. And then, of course, Vicky. So this panel is rather smaller this time. Is that right, Dr. Goldman? Anyway, high quality.
Small but a lot of punch.
Exactly. Thanks very much, Michael, for doing that.
Thank you. Okay, well, this this actually is a very interesting topic, and Chris, thank you so much for coming. You're a resource in this area, and it's so important. I have prepared a few questions that I think might be interesting for us and for the audience, and I'll be interested in getting your reaction, of course, the reaction of the panel as well. The first one is, if one looks to the guidelines, they contemplate treating to a particular dose that was used in clinical trials. But we now have, we have a number of biomarkers that one might expect that a change with treatment in those biomarkers might be markers of either successful treatment, or in fact, if they don't change, maybe not successful treatment, even though we've been able to get to guideline-based doses. Where do we stand with using biomarkers to vet our treatment effectiveness, Chris?
Well, that's really the crux of a lot of investigation ongoing now, and I think it's really highlights the controversy, I think, of biomarkers, and that is, why should we believe, and you were part of these trials, Mike, when you're at the NIH, why should we believe that the same dose of a drug should give the same efficacy to all patients in such a heterogeneous type disease state such as heart failure? Why is it? We don't do that in HIV. We don't do that in diabetes. We don't do that in many other conditions. And I think it's naive for us to say that the beta blocker dose is going to be 25 to 50 milligrams of carvedilol BID and enalapril 10 to 20 BID, Q12, and everyone will have the same benefit on mortality and morbidity and mortality. I don't think that we can be that naive anymore. If you look at oncology, nobody in oncology is giving all the breast cancer the same type of drug therapy. They're using biomarkers to not only target the therapies, but also to guide the response. And so I think we're 10 years behind our oncology colleagues, and I think that's where we need to go.
Yeah, so I guess the question is, what's the state of the art? What can we use today, and what do we have? What would we like to be able to do, and what do we have to get from where we're at to where we'd like to go? What is the state of the art? What can we use today? What can we use 10 years from now, and how do we get from here to there?
I mean, today we have basically, there's, just a handful of biomarkers, only really one, the natriuretic peptides, that people are using. It's mostly outside the guidelines right now because the body of evidence isn't that strong, although the meta-analyses are over 1,000 patients now that titrating evidence-based therapies to a target, and that's where the controversy is. What is the target? Is an absolute number, a relative drop, is believed to be associated with improved outcomes. Now that's a hypothesis we're testing in the guided study right now, an NIH-funded study that will be over 1,200 patients and powered to answer that question. But I'd like to ask Sean, how do you see the field right now? I mean, it's one that's evolving, and it's not and quite dynamic.
I was trying to think of the right analogy for this. I mean, it's kind of like we've got a flood of information, but we don't yet have the actions to follow from it. We don't yet have the right drugs or the right therapies, the next line of therapies to follow from it. But I get the sense that what we're putting together is a new paradigm. And I guess maybe the analogy is, if you go back 20 or so years ago when we had lots of computers, but we didn't have the internet yet, we were building that connectivity that led to the explosion in information technologies that we're enjoying today with big data and things like that. And I get the sense that that's what we're doing right now with some of the implantable monitoring techniques, with the new biomarkers, that we're getting this flooded data, and that's going to be in the future actionable information that we're going to be able to really translate into improvements in clinical outcomes. But I think it also requires what Chris, you said, which is that you need to define the different subpopulations in heart failure. And I completely agree with you that you can't expect that you're going to treat someone who has an inherited cardiomyopathy the same way that you're going to treat someone who has an Adriamycin acquired form of a dilated cardiomyopathy, that those are different patients, just as someone with an ischemic cardiomyopathy is a different patient. So we need better tools to define those subpopulations. And so I think what we're coming to is this synthesis, so that maybe 5 years down the road or 10 years down the road, we're actually going to be able to see a real transformation in the way that we deliver more intelligent care.
Gadget, what are your thoughts?
Yeah, I mean, I think the field of biomarkers, I mean, it's definitely interesting depending on who you speak to. I mean, those who are involved with biomarkers tend to be a lot more enthusiastic about them. I think it's taken some time for even just the adoption of just BMP, for example, into our daily practice. I think, even through the, initial from the 2002 trials up to, just more recently, there's been sort of an advocacy for maximal medical therapy. But I think what you said is very important in that we have to, define the phenotypes that we're trying to treat, and I think the biomarkers would definitely allow us to give a good idea of what we're doing is correct, as well as risk assessment, and maybe we can even alter therapy depending on what their biomarker profile shows.
So there's really two themes emerging. One is a better characterization of the heart failure patient, can we characterize the patient better than just saying ischemic or non-ischemic cardiomyopathy? That's kind of, or preserved EF and low EF. That's kind of what we do today.
Okay. Well, following up on that a little bit, if one looks at, sort of by analogy, at the whole world of sudden cardiac death, most sudden cardiac deaths actually occur in a low-risk population. And so a challenge there is to try to pick the high-risk patient out of the low-risk population. And that's of course, been a long-term challenge. Sort of by analogy, do you think we can use these biomarkers today? And if not, what do we have to do again to get from here to there? Do you think we can use biomarkers to try to pick low-risk patients out of apparently high-risk populations, and perhaps more importantly, high-risk patients out of low-risk heart failure populations?
It's not perfect. I mean, I think what we're talking about is, can we be more precise? This whole area of precision medicine. But I think that a patient who has an elevated natriuretic peptide level is a higher risk heart failure patient than one who has heart failure and not. And I'll give you a very concrete example of something that affects all of us, which was the TopCat trial that, Mike was probably involved in the planning of this many years ago. I remember when the RFAs went in. This is a trial of the aldosterone antagonist spironolactone in patients with preserved EF heart failure. A randomized trial, and it was a clinical morbidity mortality endpoint. And the trial's primary endpoint was did not reach statistical significance. However, two of the countries enrolling in the clinical trial were Russia and Georgia. And you could get in the trial one of two ways. You could get in the trial, this is people with had normal EF heart failure. You had to have either a hospitalization for heart failure in the past year, or you had to have an elevated natriuretic peptide. Well, in Georgia and Russia, they don't have natriuretic peptides as part of their care. So all the patients in those two countries got in by the history of having a hospitalization for heart failure. It turns out that their 5-year event rate was like 2%, extremely low. The U.S. population, many of the patients got in based on the natriuretic peptides. We draw natriuretic peptides. Our 5-year event rate was 5 times that. It was 10%. And so what it tells you is that the natriuretic peptide actually can absolutely tell you who is a higher risk patient or not. And TopCat would have been a clear win if they had used the natriuretic peptide as the criteria to get into the trial.
Yeah, I guess TopCat's an interesting story unto itself. I guess one of the difficulties with hospitalization for heart failure is it depends on why you hospitalize people for heart failure, and that may have been a major problem in Russia and Georgia. I would posit that the story of aldosterone antagonists in that setting remains untold. Do you want to comment on that? Because that's an important point. It's a little off topic, but...
Well, I think that in my view, if you have a patient with preserved EF who has an elevated natriuretic peptide, so you're augmenting the risk, as Vicki nicely summarized in her outline, and then you're treating these patients in the context of the way we treat patients in the United States. To me, the aldosterone antagonist appears like it's a real positive signal, and I would. Given that we're unlikely to replicate that trial, which was a massive investment and hard trial to do, I think that aldosterone antagonism in HFpEF patients should be used.
Okay. Let me change the topic just a little bit and ask a question. We've just seen the approval at long last of a device to monitor PA pressure. Which is implantable and pretty usable. It should be interesting. How do you contrast the usefulness? What do you think about the usefulness of various devices, including telemetry from some of the newer pacing devices and ICD devices? How can you compare that perhaps to the biomarkers in terms of the potential to establish prognosis and to guide treatment?
Well, it gets us even one step back and say, what is a biomarker? And if it's more than $20, it's a biomarker. If it costs less than $20, we call it a lab test. So I guess what you're asking, there's so many things that are actually really biomarkers. Hemodynamics are biomarkers. Creatinine, serum sodium are biomarkers, but they're under the $20, so we call them lab tests. But I think what you're suggesting, Mike, is important, that the recent studies targeting invasive hemodynamic measurements with, again, evidence-based therapy to targets of what we think is an optimized hemodynamic measurement appears to reduce heart failure hospitalizations. And Sean, you should comment on this, because I think what's going to happen to us as clinicians managing these patients is just what Sean said earlier, is that there's going to be so much data out there. How are we going to manage all this data? Because right now we have the data off the ICD and BIV pacers, and we're not, at least at Duke, we can't handle it. We can't handle the impedance and the heart rate variability and all the data that's coming off those. We're not integrating it in a very useful way. So,
Sean, what do you think of that? I mean, we now have the ability to monitor PA pressures. We actually have the ability to monitor other things. How do you see that integrating into our practice?
I was initially a little surprised that the CardioMEMS study was positive, because if you extrapolate from the inpatient experience with ESCAPE, which the use of a PA catheter in all patients randomized to, all patients admitted with decompensated heart failure who were eligible for enrollment in that trial, there was no added benefit to PA-guided therapy. We also had learned prior to that there was some debate as to whether or not goal-directed therapy or hemodynamic-directed therapy worked in acute decompensated heart failure, treating to lower CVP and wedge pressures and also a higher cardiac output. Work that Len Stevenson and Greg Fonero had done many, many years ago when they were together in LA. So with that as prologue, I was a little dubious as to whether or not monitoring PA pressure as an outpatient would be positive, and yet the CardioMEMS, as we heard, reduced heart failure hospitalizations over a reasonable time course of like 12 weeks or so, and extended out over a year or so, with about 25 to 30% reduction in heart failure hospitalizations. But all data is only as good as if it's actionable, and so a biomarker doesn't make a patient better, a pressure monitor doesn't make a patient better, a physician makes a patient better, or a physician makes a patient worse. And so what really you need in the back end is a physician, a practitioner, to take that data, synthesize it, and make the right treatment decision based upon it. And so right now we haven't defined how we're going to act upon the data that we're getting. We haven't defined who those patients are going to be who would require or significantly benefit from the implantation of an implantable device. CardioMEMS maybe enrolled 250, 300 patients or so. It's a relatively small number of patients, but you can imagine, even though the device was safe in that trial, when you start putting this into thousands or tens of thousands of patients, untoward events are going to pop up, and we really have to ask, is the data that we're getting from this device really going to be worth putting patients at risk for putting the device in? So I don't think I really answered your question directly, which is how are we managing this, or how are we going to incorporate it into our own clinical practice here. But I think what we're going to do is we're going to first define who are the patients who are going to benefit most from this type of monitoring. And then second, we're going to have to decide how is that information going to stream in, and are we going to look at it first, or our nurse practitioner is going to look at it first? And then the third thing we're going to have to define is what are we going to do with that? Are we going to have patients come in for a rapid follow-up? Are they going to come into an infusion clinic? Are they going to come into the hospital based upon that data? And the simple answer is we don't know, but I think it's about time we got our feet wet and figured it out.
Vicki, how do you think we can figure all this out? The usefulness of a CardioMEMS device that gives us pulmonary artery pressures versus perhaps using biomarkers. Any thoughts? You're the new generation of us.
Well, after a lot of reading, I know that the biomarkers actually are very tightly correlate tightly with PA pressures, and so if we use both of them in combination, maybe we'd able to risk stratify patients before that and see who's going to be those that are more at risk, and basically, before putting somebody through an invasive procedure, weed out those that may benefit better from that type of procedure. Because they both correlate, I'm not sure how one versus the other may be better, but one's less invasive, so I think that's yet to be seen.
Jith, what about you? Have a huge heart failure practice. Do you think this has that device has any legs? How would you integrate it, and so forth?
I mean, I think the problem, as Dr. O'Connor mentioned, is just information overload. I mean, I think anytime you introduce multiple variables, multiple different people interpreting data, it kind of dilutes what you get. And I think the beauty of biomarkers is that not only as cardiologists can you interpret the data, but it's really made for the vast sort of internists, emergency room doctors, etc., to quickly diagnose these patients and help guide therapy. And the fact is that a CardioMEMS device will probably help our subgroup of heart failure physicians, but I think the biomarkers are applicable to a larger majority of patients and are less susceptible to sort of interpretation.
Mike, one of the trials also that looked at impedance, which was sort of an indirect measure of hemodynamics. What happened is that as the impedance went into an abnormal range, there was a signal that went off, and the patients were told to go to the emergency room. And so in this trial that was done in the Netherlands, the rate of heart failure hospitalization actually increased because they got early detection of changing impedance, or maybe worsening hemodynamics, and they because of their health system couldn't accommodate them in the heart failure specialist, they went to the emergency room. The emergency room doctors didn't know what to do with this device showing abnormalities in hemodynamic trends, so they said, we better admit the patient. So they all got admitted. And so they had actually a twofold higher increase in heart failure hospitalizations because of the, now whether that makes the patient, maybe you tuned them up and they have less mortality, we'll never know. But that's one of the dangers of implementing these broadly into society, is understanding how to use the information.
One of the difficulties with clinical trials that we're all feeling acutely is the cost of doing endpoint trials is of course huge, and in an era of budget constraint, it's particularly painful because it really limits the number of studies we can do. One would like to develop surrogate markers. Obviously, they have a checkered past. Do you see which of the biomarkers do you see as reasonable surrogates for heart failure hospitalization and cardiovascular death?
Yes.
Or are there any? I mean, it's fair to say there are none.
The natriuretic peptides are again, as much as we say over and over, they have been integrated into composite endpoints for phase 2 studies now. So if you look not only in heart failure but in ACS, they just published the Reminder trial, which was a Plerinone post-STEMI MI with a composite endpoint of BNP plus heart failure hospitalization plus death, all driven by the BNP, but everything went in the right direction. So in the heart failure network, where we do phase 2 studies, our endpoints are usually at 6 months, delta BNP, heart failure hospitalization plus death. And these are 200 patient trials, so all the power is being driven by the delta BNP. So there is a belief that can be used as a component of a composite endpoint to reduce the sample size of clinical trials, see if there's a signal, and then obviously you have to verify that in larger trials. The other, quote, biomarker, not really used this way, but is left ventricular volumes. Almost every advance in a therapy that we've had in the outpatient setting that has improved survival has also improved left ventricular volumes. If you look at ACE inhibitors, beta blockers, aldosterone antagonists, CRT. So that's I think a surrogate endpoint that could be utilized too. But I'd like to hear what Sean and Andrew have to say about it.
So I was trying to think about how we can define these subpopulations of patients with heart failure, because I think one of the cardinal rules of clinical trials is that if you do a randomized clinical trial and you enroll an adequate number of patients, that if you come up with a primary endpoint, that primary endpoint applies to all patients regardless of what their patient demographic is. And then if you think about if you were to step away from it, I think that's a principle of qualitative interactions. I'm trying to remember back to Bob Califf's series of articles in circulation about 10 years or so ago, which is a great resource. But that's been the rule that we've always followed in heart failure, which is that if you have a patient who has heart failure, you treat them with an ACE inhibitor because clinical trials showed that ACE inhibitors save lives. Same thing with beta blockers, same thing with Spironolactone. And when we began to delve into different subpopulations, our first foray into this, I think, was the BEST trial, which, Mike, you know extremely well, and really took us onto a road that was a dead end, I think. I mean, Mike Bristow's still looking at different beta receptor subtypes and whatnot, but how do we go from treating everyone the same as heart failure to defining those subpopulations? I think what you're doing is you're pointing us in the right direction, which is that if you can break it down into these three endpoints, change in BNP, heart failure, hospitalization, and death, you can have a smaller number. You can therefore do more clinical trials in a more tightly defined subpopulation of heart failure patients without exploding the cost of trying to test each individual therapy.
Yeah, let me say, I want to say one word in defense of BEST, which looked at bucindolol and came with a strong trend suggesting what all the other trials were suggesting, that is that beta blockers improve mortality in heart failure. Actually, BEST was shut down by the DSMB because of the totality of data were already out there. And I think the bucindolol probably got a bad name as a result. But one of the things that's interesting and goes to the topic that we're talking about in terms of heterogeneity of risk is when we looked at the population of patients in that trial of bucindolol, our population was very different. There were no blacks in the other trials. There were in ours. And while it was perhaps political correctness motivating it on the part of NIH originally, what we saw was that if you pulled out the blacks out of the population, what you saw was a point estimate for harm in that group, a point estimate for harm. And it didn't reach it didn't reach statistical significance. It's a relatively small group. But if you pulled them out, then that trial looked like all of the other beta blocker trials, and it suggests the heterogeneity of the population. There, it's clearly a crude phenotypic marker of something more fundamental. But it goes to the business of trying to pick subpopulations out of the larger population. There really is heterogeneity of risk that we don't really, I think, fully understand. In fact, I think one of the problems is if we better understood the heterogeneity of risk, one might be in a position to better target what biomarkers we want to look at. I don't know, perhaps, Chris, perhaps you could comment on that, or maybe it's not a useful observation, but the whole business of the heterogeneity is a big deal in that heart failure world.
Well, it really is, and we don't, again, our oncology colleagues, we're not treating, and there's not development of new cancer agents just based on the broad definition of cancer. They're really looking at marker positive, marker negative, and going in, and they actually, when they're pretty sophisticated. When they do their trials, they have the hypothesis set up to really test if in the subgroups they're positive. So there's been a number of agents in which the primary was not statistically significant, but they had pre-specified that in this marker positive type of cancer it will be, and they got hit on that, and they've been approved. And so I think we have to do a better job of predefining a much more homogeneous phenotype. I do want to say one thing about American medicine and what is somewhat sad, although we get a lot of credit for doing clinical trials at Duke. I wear my Heart Center hat. We just did an analysis, and only 2% of the patients coming through Duke's clinical service are entered in clinical trials. And it turns out that patients entered in clinical trials contribute 50% more to the bottom line of the hospital than patients not entered in cardiovascular clinical trials. And whether that's because MRIs are paid for at managed care prices and you have this additional testing funded by the test. But I think if we're going to really try to answer all these questions, we've got to have a commitment that, like the oncologists, which is closer to 50% are entered in clinical trials.
Yeah, I guess the question one might ask is, who's going to pay for it? Because in the end, it's zero sum is the wrong term, but there's only so much money that's going to be poured into these clinical trials. So the question is, who's going to support, who is going to support Duke on this?
Well, we have to be smarter in doing the clinical trials. We can't do $100 million trials you can only do 5 big trials in your life if you do what I've been doing, and I've done 4 of them, so I've got only 1 more trial left in my life, is the way I look at it. But we've got to be smarter. Like what we're talking about now, we have a proposal to the NIH is that every heart failure admission to the hospital will be entered into the clinical trial, this randomized trial, furosemide versus torsemide. And we're going to use EPIC as to populate the case report form, and we're going to have a central office to just use the National Death Index to look at survival, and it's going to be an 8,000 patient trial. We hope to get Sinai involved because I understand you struggle with EPIC just as much as I do, so we might as well share the pain. But we've got to figure out how to do trials like that, that can be fast, that don't take a lot of energy to fill out the case report form and give us a definitive answer.
There are actually some national resources. One that is largely untapped is the military database. It's unfortunate that the CHCS system that they're using is so difficult to try to do. It doesn't do what EPIC does. It just won't populate it that easily. There's too much text and so forth. But there you have a real cross-section of the entire U.S. population. It's a beautiful cross-section. It's old, it's young, it's male, it's female, it's every race, every ethnic group's represented. It's totally untapped, much more so than who's admitted to Mount Sinai or who's admitted to the Duke Medical Center and to your satellite. So it's very interesting. The whole business is really trying to tap some of these systems. Some of the big HMOs probably fit into that paradigm. Let me ask one other question that goes to the business of drugs and development, and it's a little bit off center, but it springs from this discussion, and that is, what do you see as the future of drug development in the heart failure world? We've hit on difficult times. There are not a whole lot of new drugs that that are really that appear near use. Where do we stand on drug development for the treatment of heart failure?
Well, it's sad, isn't it, that you can make a pharmaceutical company can make more money if they can develop a drug that keeps your eye more moist than improving survival. I mean, survival trials are hard to do, and they're expensive, and that's why we've got to change the paradigm on the way we do these trials so that they can be done cheaper. I think what's exciting right now is that we have 2 large clinical trials ongoing, one with serelaxin and one with ularitide. These are both vasodilators, sort of novel vasodilators in acute heart failure. And they're planning to enroll 5,000 patients. Enrollment's going reasonably well globally. U.S. usually lags a little bit behind, but I think both of those have learned the lessons from Ascend, which I was a PI on, and we crashed and burned with nasiritide, and that is, we talked about this earlier. Time to treatment is important in acute heart failure, and subsetting the patient population so that you're treating patients who have a phenotype that are hypertensive and have elevated natriuretic peptides. So these are patients who are most likely going to benefit probably from a vasodilator. You wouldn't want to give a vasodilator to somebody who's coming in with systolic blood pressure at 90. And I think we learned a lesson that low natriuretic peptide levels, probably there's no events and not much response can be shown. So, Sean, what else do you see in the field?
Well, the one thing that we're hoping for is omecamtiv mecarbil, which is hopefully the first quote-unquote safe positive inotropic drug, which acts to potentiate systole. It extends systole. It's a myosin activator, which apparently does not increase myocardial oxygen demand, does not increase DPDT, and the hope is that that might actually translate into a boost in cardiac output by increasing stroke volume without increasing myocardial oxygen demand. Some preliminary data looks okay. That was the Merlin trial, I think it was, which looked at omecamtiv in a phase 2 trial. There are a couple other new drugs that are coming out which are kind of interesting. The neprilysin inhibitors are out there again, looking to potentiate the effects of the natriuretic peptides, the endogenous natriuretic peptides. So combining that with an ARB, I forget what it's LCZ something something something, I think is the name of the drug. And then there's another drug which looks at these biased ligands. So you can bind to the AT1 receptor, and it can block the vasoconstriction and the drop-in GFR that occurs with binding to the AT1, but doesn't have the negative inotropic effect that typically occurs as a result of that. So you get all the channeling into positive inotropy, and you block the untoward vasoconstriction and drop in renal perfusion that follows. So these are some interesting things, new paradigms that we're looking at. A lot of these are in the acute setting rather than in the chronic setting. But I think we're going to need to come up with new paradigms to explain the heart failure state. I think we've taken the neurohormonal hypothesis about as far as we can go, and I think we need to come up with a new synthesis, something that can also boost cardiac output like omecamtiv without increasing myocardial oxygen demand.
The only other one that I would mention along with that had approval in Europe but not here yet would be something like Evadrobine, which we haven't had the opportunity to use here, which hopefully we will have. But I think that goes back to sort of sympathetic modulation, heart rate control, and getting back there. And I think it will have applications to heart failure plus other disease states within cardiology.
One of the things that Sean brought up that I think was a nice concept is, why did we see an uncoupling in the ESCAPE trial, which is where we optimize hemodynamics acutely in the hospital with a PA catheter versus expert clinical care? And it may have been because the expert clinical cares were really good doctors like Lynn Stevenson and other. They beat the Swan and Mark Drasner. But why didn't we see a benefit in the ESCAPE trial, but we're seeing it in the CardioMEMS? And I think a concept that Dr. Fuster taught me when he was the PI of the CARS study is time in therapeutic window. And so one of the things we're beginning to see in heart failure is how much time do you spend suppressed the natriuretic peptide levels or the hemodynamics. It's like the INR. You can't just have a transient. What we think happened in ESCAPE is that we got it all done and packaged really well within 72 hours. Then we pulled the catheters out and we were switching from IV furosemide to PO, and then the hemodynamics slipped back up. And actually what we can show in the ESCAPE trial, Monica Shaw and I showed this, is that and this was pretty early when the assays were, the Shinogi assay wasn't that great an assay, but the natriuretic peptide levels were the same at day 7 in the two arms. So we must have slipped, in the hemodynamics before they went home. And so I think the concept of time in therapeutic window and suppression over time is a key one.
I think what I'd like to do is we're getting late into this session. I'd like to open this to the audience and ask whether you have questions as well. I've had the pleasure of being able to ask the ones I had, and wonder if you have questions as well.
So Mike, I wonder if I can ask Dr. O'Connor a question. So I know that you're participating in GUIDED, but right now we're using biomarker-guided therapy to adjust your either inpatient or outpatient care of heart failure patients.
Yeah, I have to confess to this crime that I do, even though we're supposed to have equipoise in randomized trials, and I do try to enroll patients in GUIDED first. If I'm rounding on the inpatient heart failure service, and this is something that my fellows and residents know, that we have this, I call it the Quadratic Vector, and we use a clinical exam, renal function, natriuretic peptide, and weight. And we try to develop this information day to day. I tell my residents and interns, they always say, O'Connor's coming on the service, get ready for the quadratic vector. And but we really I look for about a 30% drop in natriuretic peptide levels from day 1 to let's say day 5 is the average length of stay. And if they don't drop, I'll probably keep them in a hospital an extra day and up-titrate all their medicines as best I can. And I'm trying to convince our hospital administrators to see if they would fund that trial, to keep them an extra day to up-titrate the medicines so the length of stay goes up from 5 to 6, but you could reduce readmission rates.
Yeah. I was reminded of, I heard Jim Fang give a talk last year, and he reminded me of a study that Milton Packard did when he was here at Mount Sinai. And I think, Jose, you were a co-author on this too, where he essentially he put a swan in patients with decompensated heart failure, put them in the CCU, and you could only do this 20-some years ago, and it did nothing. He didn't treat them at all. He just kept them in the CCU, and what he showed is that over about 48 hours, everything normalized. Their hemodynamics got better, their cardiac output went up, their CVP, their wedge pressure went down, they got better, and they felt better. And part of it is, I think, when you're out of the hospital, you don't realize how much patients really go and exert themselves. But when you're just lying there in a bed, they feel better. The way I incorporate that into my own thinking is that if you put someone and you put them in the hospital and you give them a couple doses of IV diuretic, within 48 hours, whether you gave them the diuretic or not, generally they're going to be feeling better. And the temptation then is to send them home. And the reality is that if you had the quadratic vector, you should probably copyright that or something, But if you had that, you could actually show that you need to treat them a little bit more, even if the orthopnea has improved, even if they're feeling better, even if they're taking at least one lap around the nurse's station. Really go until they're dry. And I think that although we really do try to teach the physical exam here, and we really do try to teach how important it is to look at the CVP, it's sort of like a good baseball hitter is an all-star if you can hit the ball 3 times out of 10. I think you're an all-star if you can get the JVP right at least 5 times out of 10. But it's not 100% perfect, and I think I'm like you. I do kind of cheat too, and I do like following the biomarkers, whereas if you had asked me that a couple of years ago, I would have said no. But we definitely do it now. We're trying to make it part of our own PI program here, that we get a BNP level when they come into the hospital, a BNP level when they leave the hospital. Keep them here a day or two more if they need to get it down below, at least a 30% or 50% reduction in their admission BNP. And then we follow it again when they come in for rapid follow-up within a week of their discharge. So we're just kind of rolling that out now. We've had, a few dozen patients come through with that, but it's really a big PI program here for us over the next 12 months, and I think we're on to something.
Chris, are you using any biomarkers to follow patients with LVADs in place?
We're exploring that, and sort of, we have a biobank of our LVAD patients, and we're looking at how the biomarkers and even more refined metabolomics are changing over time with the LVAD. There's, I think it's a very exciting area to see if there are populations you could use biomarkers to guide whether it would be worth an attempt to remove LVAD therapy. There's a lot of interest in this recovery concept, Sean, and you know more about this than I do, but I think that's a really good area for research.
I think there was an interesting paper actually from Duke that will be going into JAK heart failure that showed that, despite significant improvements in, overall clinical status and, 6-minute walk, most of the biomarkers did not actually improve, suggesting that, goes along with the 1% or less of patients who actually would recover.
No, I just have a comment. Obviously, the topic today is biomarkers. So you are really dealing with cardiac disease already, I would say, reasonably advanced. Now, my question to you is that when you look at the future of cardiac failure, it seems to me that the great challenge is to discover things much earlier. And I can give you 2 or 3 examples. For example, in myocardial infarction, obviously, once you have a myocardial infarction, what can you do? But the issue, for example, of the recent trial showing how much you can do in the ambulance with the blood pressure oscillating there up and down and giving beta blockers. This is new. You can prevent to go into significant cardiac failure. The issue of alcohol. how many people we see who they are really drink a lot and they develop a cardiomyopathy. Could we do something earlier? And the issue of valvular heart disease. So what I'm really trying to say is that I think the biomarker is an interesting field, but I still think that we should obsessively go for the very early stages. And to me, that's where at least where I see a great future, because all the rest, I'm not sure how much we are going to accomplish. For example, on the trials that are being presented, as you know, the length of life that you prolong is very short. It's statistically significant, sure, but you live
months.
What, 2 more months, 3 more months, and so what? So what I'm saying is maybe we should move into
earlier,
some kind of much earlier, and trying to identify the different causes of cardiomyopathy and see what you could do earlier. Just a comment.
Well, I think it's very important. I mean, I think we get excited as heart failure doctors about the sicker patients, and you can see changes and you see the response when you put an LVAD, a CRT, great medical therapy. But Dr. Fuster's exactly right. Is what heart failure is we sometimes we shy away from the term failure because we think there's successes, but it is a failure of some extent. It's a failure of 70% is due to coronary disease, and 70% of those is due to myocardial infarction. So, we've failed in that sense, and then the other big percent is hypertension. And so, if we really want to impact on heart failure, we have to go upstream to stage A, and we have to think about how we could maybe more aggressively treat in the asymptomatic stage. And the biomarkers are helpful there. It's just a different cutoff. And there may be different types of biomarkers and maybe the higher sensitivity of biomarkers that we'll be using. But if you look at patients in the cardiovascular health study, Framingham, biomarkers that we're talking about today do afford, can triage risk. And so maybe in those patients who have these smaller elevations in natriuretic peptides or troponins, maybe you would say as a choice for antihypertensive therapy, you would go with a RAS inhibition as opposed to a calcium blocker of somebody who is at higher risk for developing heart failure, even though the guidelines would say that you could use those interchangeably in all hypertension.
Yes.
Thank you so much, Dr. O'Connor. I just wanted to ask you, can you just comment on how you use biomarkers in the management, inpatient and outpatient, of your pulmonary hypertension patients?
Yeah, that's a good question. The pulmonary hypertension patients are, a big, complicated population now. We see a lot of secondary pulmonary hypertension in our heart failure service, and we have a big lung transplant with the pulmonary hypertension. I don't think the evidence is as strong on how to use serial markers in patients with pulmonary hypertension. I can say anecdotally that that I use natriuretic peptides to monitor my patients with who have secondary pulmonary hypertension, advanced heart failure, and that there does appear to be a pretty significant change in slope when these patients begin to decompensate, and we'll be much more aggressive with vasodilator therapies in those patients. But I think it's an open book. Sean?
I'm actually going to defer to Ajith since he directs our pulmonary hypertension program.
Yeah.
Well, I think as far as biomarkers on the outpatient side, elevated BNPs in the REVEAL registry, which was a big U.S. registry in PH patients, was shown to correlate to negative outcomes. Certainly a lot of the biomarkers that have been validated in heart failure have also been, galectin-3, BNP, of course, and a few of the other ones have been shown to correlate to survival as far as pH is concerned. But that's obviously a small subset of patients, a small population of patients compared to the vast, heart failure majority. But I certainly use BNP on every single patient that comes in as an outpatient for the pH patients, just to get an idea of what's going on with the right ventricle.
Mm-hmm. Marianne?
Dr. O'Connor, you mentioned in your quadratic vector renal function, but we haven't talked yet about the effect of the renal function on the markers, such as we know 30% of patients with heart failure, at least 30%, have significantly impaired renal function. And what does that mean in looking at the levels of BNP? And are you including those patients in the guided trial? Or is there a cutoff? renal function?
Yeah, well, we're including patients with significant renal insufficiency in the guided trial. I think the creatinine cutoff is 3.5. But it's a very good point, and that is the interaction of the kidney function and these markers of hemodynamic stress. And it looks like these markers, certainly natriuretic peptides and troponin, do add independent prognostic information in these patients, so that the creatinine, the BUN are highly valuable. Actually, they seem to perform even better than cystatin C or some of the novel renal markers. But the natriuretic peptide adds value above and beyond that, so as does troponin. So I think that we're going to have to begin to integrate into our thinking a multi-marker integration of that information, and it can get complex when you're sitting at the bedside with a patient.
Can I ask a question? You mentioned the quadratic vector. Why not add a fifth point, the point of care echo? It seems that a lot of things you mentioned earlier today, talking about LV volumes and filling pressure, those are hard to get, and I think part of the art of that is getting lost. But you can look at point of care echo to get some idea of the mechanism, because there's such heterogeneity. Which of these have preserved ejection fraction? Which of those patients have a lot of regurgitation? Looking at the IVC, looking at pleural effusions. Why isn't that being promoted at the bedside point of care, and titrate therapy almost daily like you would on weights, looking at the response to your therapy?
It's a great question, the point of care echo. I think the problem is, as I see it, is sort of, are we going to be able to disseminate the skill set to do that, which would require point of care interpretation, to the broad population of healthcare providers that care for heart failure patients, which is, as you know, it's not going to be heart failure specialists and imaging specialists who care for these patients broadly. It's going to be physician extenders and generalists and primary care doctors. And I think that's the barrier I've seen, that when you get a natriuretic peptide, you say, well, if you're above 1,000 or below 1,000, this is what you do. But what you just described, which I like that concept a lot, but I don't know if I can sell that to the broad population of providers.
We're going to try to take a small step, a small crack at that. So we have two protocols. One's an outpatient, one's an inpatient protocol, using just looking at IVC diameter and using that to guide treatment decisions surrounding diuretic use. So one, in the outpatient arena, patients will be randomized to either handheld echo looking at IVC diameter and IVC collapse to guide diuretic therapy versus standard of care. And then a similar protocol, but in the inpatient setting. And in fact, we just randomized 2 patients today to this trial. Both are control, thank goodness, because I'm on service. But it's a small step, and just looking to see if there's one echo parameter that we can follow to provide a little bit more information, similar to using it like a biomarker, to see whether or not we can actually improve the level of care that we provide.
Marty, one of the things about a question like that is what's the question? If the question is what echo parameter can we use that would make our heart failure treatment more effective in terms of some real endpoint, readmissions, maybe even first heart failure admission if you're talking about people who are at risk but haven't had it, or for that matter, just vetting therapy. I think trying to parse out whether it was point of care or whether a tech drove down there would be a pretty heavy oar to pull. So I suspect that it's less the point of care than the use of some marker, whether it's volume or IVC diameter or whatever. I think it'd be hard to parse out the point of care part of it, though. Okay. Are there other questions from the audience? Well, Chris, thank you so much for being with us, and we've really enjoyed it. It's been helpful, and we appreciate your coming.
Thank you very much. Let's see if USA can grab a win here. Thank you. You're doing great. Thank you. Keep in touch.
Yeah. That was a lot of fun. Yeah, it was a lot of fun. I told Mike we should. Yeah, I would love to. That was such your best. Yeah. And I told Mike, I said, Mike, thanks.
Yeah, thank you. Yeah. No worries. Yeah. All right, I hear you may be in the transition. Yeah. It's not fun.